Good evening, everyone. I'm Tanya Winders, the President and CEO of Allergy and Asthma Network, and it is my pleasure to welcome you this evening to the second in our series of Black People Like Me webinars. Tonight, our title is African Americans and Research, Making It Work for Folks Like Us. And we are so honored and privileged to have all of you here with us from across the country. This series of Black People Like Me webinars is brought to you tonight by Allergy and Asthma Network through a PCORI funded cooperative agreement and grant. And we are so grateful for PCORI and their support of our mission to end needless death and suffering due to allergies, asthma, and related conditions. This evening, I am honored to be joined by our two illustrious presenters, Dr. Elliot Israel, who is from the Harvard Medical School in Boston, Massachusetts, and Mary White, our patient partner, who will be sharing much of her experience of living with these conditions and participating in research. I'm also joined by my co-host, Dr. Leroy Graham, who is our primary investigator on this PCORI-funded grant project. And Dr. Graham is a pediatric pulmonologist who has led the Not One More Life community outreach program to, again, address disparities and inequities in respiratory care. So again, as far as our agenda and time this evening, we start out with a welcome, just as I mentioned. Then we will go through an overview of the impact that asthma currently has on the Black community. And we'll give some insight into patient-centered research studies for African American patients with asthma specifically. Then we will have our patient partner interview and finalize our time with a question and answer session. So we do have several objectives that we are highlighting this evening. The first is that we would like to understand the unequal impact of asthma on Black populations in the US. And the second is that we'd like to understand the role that patients can play in advancing the treatment of asthma. And so at this time, we are going to begin. I'm sorry. I wanted to make sure, yes. Okay, sorry, wanted to make sure we were recording. I did not see the recording button, but we are, so all the technology is working as we need it. I am gonna ask if you are not actively speaking to please mute your line. We are getting just a touch of feedback on the line at this point. So if you're not speaking, please go ahead and mute your line. And you can also turn off your camera if you are not the active speaker on camera at the time. Again, as I mentioned before, we have two very important guest speakers this evening. The first is Dr. Elliot Israel, who is an asthma specialist and the principal investigator on the PREPARE study. And second is Ms. Mary White. She's a community asthma educator and patient partner advisor on the PREPARE study. And you'll be hearing from both throughout our time together. So first, I'm going to field the first question to Dr. Israel. Dr. Israel, we're so glad that you're with us here tonight and really appreciate your time, but share with us why you were even interested in asthma in the African American population to begin with.
Yeah, thanks so much, Tanya. And I wanted to thank you and Leroy and PCORI for organizing this event and giving us an opportunity to talk with so many people. I wanted to thank the audience for tuning in because asthma, as I think you know, is a disease that really disproportionately impacts Black and African American populations. And the reason I became interested in studying asthma in Black and African American populations is that the data, as you'll see, really suggests that there is a very disproportionate impact. And one of the goals that why I went into medicine, one of the goals that I study asthma is to help make people better. And there's a group of people, African Americans and Blacks, and it also includes Hispanics and Latinos, who, as compared to white people, really have much more asthma. their asthma is worse, and we're going to talk about how much worse in a little while. And the questions I began to ask as a researcher in asthma is, why is that happening? And what can we do about that? And we know, for instance, that for example, for blood pressure, that there are medications that are more effective in Black populations than they are in white populations. And actually, after studying Black populations, we began to realize that what should happen in terms of managing high blood pressure is that we should be using different medications in different order for Black patients or African American patients than we should for whites. And so some of the questions I began to ask myself is, well, why are we seeing this difference? Is part of the problem maybe that Blacks or African Americans have a different type of reaction to the medications? Should we be using different medications? And I'll touch briefly on a study that we did to kind of look at that. And then the other I asked is, and we're going to talk about this, is that the reason that, for instance, the blood pressure problem and the different medications wasn't discovered is that many studies to approve medications and to understand whether medications work do not include African American and Black populations or include very small numbers. And there are different reasons for that. I think we're going to talk a little bit about some of the possible reasons for that. But the problem is, if there's a different type of response, or there's a different type of problem, or there's a different type of reason that you're having your asthma, and you're not being studied, then the types of medications and the interventions that are being proposed are not necessarily ones that will work for you. And so if I prove that an approach works in a group of patients and it doesn't include hardly any African Americans or Blacks, how am I sure that that really would work for that population? And since so much of the morbidity or the bad effects of asthma are occurring disproportionately in this population, I felt we had an obligation to look at that and try to figure out whether there are interventions that will help. So that's how I got started in this area.
Absolutely. Well, again, thank you for expressing that, sharing that with us. And we wholeheartedly agree. I mean, this is unfortunately what we hear all the time in direct conversations with patients and caregivers and healthcare providers from across the country. And especially when it comes to research, we see that there is an underestimation or under involvement of those individuals from underserved communities and minorities. So we're going to be very interactive tonight. And with our technology, we can actually take polls. And I'll turn it over to Dr. Israel now to go through the flow. And we will be polling and asking you to respond at the appropriate times. Dr. Israel?
Yeah, so I was hoping that we could understand what the impact has been for people in this audience. And so the first question is, if you have asthma, how many times have you gone to an emergency room or urgent care for your asthma in the past year? And you can see A is 0 times in the past year, B is 1 time in the past year, C is 2 times in the past year, D is 3 times in the past year, E is 4 times in the past year, and F is 5 or more times in the past year. So how many times have you had to reach out and gone to an emergency room or urgent care in the past year?
So we'll leave the poll open for just a few moments. I do see that hundreds of people are logging on their responses at this point. I mentioned earlier, we do have over 1,000 people registered for this evening.
Wow.
And well over, it looks like about 400 already on the line and actively participating. So we'll give it just another moment and then we'll share the responses of the poll. All right, I'm going to go ahead and close, oops, wrong place there. Close the poll and share the results. And Dr. Israel, you should be able to see those on the screen,
yes,
correct?
And does everybody else? So you can see that 18%, so almost 1 out of every 5 people in the audience who have asthma said that they've had to go to the emergency room at least once in the past year. Almost 5% have gone twice, another 5% have gone 3 times, and 1% has gone 4 times, and 1% has gone 5 or more. This is a large group, so 30% of the population that is here today has gone to the emergency room at least once, which is really pretty high for an asthma population. And I think we're going to talk a little bit more about that. So I think we're seeing what others have reported. And so let's go on to the next question then. Tanya, are you able to advance
Yes.
the? Yeah.
So let's see, sorry. Okay.
So let me ask this question for you to have a sense. I'm going to ask several questions about what you think the impact of asthma is on the Black community. And so one of the questions is, asthma happens in African Americans or Blacks at what rate compared to Caucasians? So this is, how often does asthma happen? Not how bad it is, but just how often does asthma happen? Do 10 people out of 100 have asthma? Or is it higher or lower? So is it occurring at the same rate as Caucasians? 15% higher, 35% higher, 50% higher?
I'm sorry, we actually have the wrong poll up here. The technology is not quite accurate. It's still asking that last question. So give me just a moment.
I think the next question.
Yeah, I'm sorry. The technology did. There we go. Poll. Okay, let's try again. So now we have launched the poll that is on the screen as well. So if you'll please enter your response. So what is your belief on asthma occurrence in African Americans at what rate compared to Caucasians? Looks like we'll leave it open for just another moment. A lot of responses are still coming in. All right, we're going to close the poll and share the results with you all.
Okay. So I'm not going to give the answer. You're going to hear it a little bit later. But a very small portion you thought it was the same rate. More than half of you thought it was 35% higher, and a third of you thought it was 50% higher. Let's keep that in mind as we go along later.
Okay.
So the next question in terms of impact on the Black community. African Americans or Blacks are how many times more likely to go to the emergency room or to be hospitalized for asthma than Caucasians? The same number of times, 2 times, or 5 times?
So the poll is now open. Again, if you'll cast your vote, we're going to get very good at this by the end of the time this evening. Lots of polls. We love that interactivity. Makes the webinar go by much faster and everyone stay engaged. So we'll leave it open just another second. Looks like we've got about 2/3 of the vote, almost 3/4. We'll close the poll and share.
And so it's almost even in terms of people thinking it's 2 times more and 5 times more. Okay. And the last one, the death rate for African Americans and Blacks with asthma compared to Caucasians. No difference, both are the same. 1.5 times more, 2 to 3 times more, 10 times more.
Again, the votes are coming in quickly. All right, looks like we've got about 3/4. So we'll share the results.
So the majority of you thought it was 2 to 3 times higher. Almost a third thought it was 10 times higher. And about 10% thought it was 1.5 times higher. Okay. If we go on to the next slide. So to just answer the questions we asked, so asthma occurs at a 35% higher, so about a third higher rate. So if you take 100 people, and let's say 10 of them, 10 Caucasians would have asthma out of those 100, about 13 to 14 African American Blacks would have that. And it's 100% higher in Hispanic Latinx So 20 of those 100 would have asthma. Both African Americans and Blacks and Hispanic Latinx people have double the rates of asthma-related emergency room visits and hospitalizations as Caucasians, and 50% higher rates of rehospitalization. So there are twice as many emergency room visits and hospitalizations. And most of you picked the right one. African American Blacks experience 2 to 3 times the deaths due to asthma as Caucasians. And all of this has been difficult to improve. And if you look over here on the side here, you can see in terms of emergency room visits, African American children, 4.5 times higher, 7 times higher than Caucasians. African American adults, 2 to 3 times higher for ER visits and deaths. And Hispanic children, 2 times higher. So there's a big disparity here in terms of the rates of both asthma, when asthma is occurring, but not only in terms of asthma occurring, asthma seems to be more severe for African American and Blacks, as evidenced by the fact they have to go to the emergency room more often, they have to be hospitalized more often, and they die more often from their asthma. Next slide, please. So why and how do we do medical research? So, when Tonya asked me, why we do this, I said, I do research, and I do research because as a physician, I would like to improve the lives of the people I treat. And one of the ways, at least that I can do that, besides seeing patients, is trying to understand how to better manage patients and whether there are better treatments or better options. And so we do research to understand a particular concern about human health, such as what can be done in the case of asthma to minimize asthma deaths or asthma problems in African American Blacks. And so research is a little bit different than kind of going to see your doctor and saying, "Doctor, I'm not feeling well," can you give me something? What does it involve? You have to decide on a question that you want to answer. If you've decided on the question you want to answer, like, well, okay, why is there more asthma in African Americans? You can then say, okay, what kind of information do I need to try to answer that question? And usually you try to kind of come up with a hypothesis, or what's your guess as to why that might be? And then you try to gather the information that'll help prove that or not. So you collect the information in a way that you can analyze the information. And then once you've collected that information, you can analyze and figure out what the information means. And then if you come to some conclusion and you say, aha, I think I've found an answer, you can try to get that information out to those who are impacted. And the impacted groups can be patients, the communities, healthcare providers, healthcare policymakers, and payers as well, right? All of them are impacted as we talk about the bigger medical system. Next slide, please. So thinking about research, let me ask members of the audience this. How much do you trust researchers? Medical researchers, that is? A lot, a little, not very much, or not at all. And nobody's identifying you, so you can feel free to say what you really feel. Okay, so 43% of you said a lot, 49% of you said a little, and 8% of you said not very much. So yeah, I think that's better than the general African American community. I think there's a lot of distrust of medical research, but at least almost half of you said you trust research a lot. That is great. Next slide, please. And I want to talk a little bit about why we do research and how we do research a little more, so you can understand why it's important, potentially, if you want to advance the treatment of things like asthma, how you can make contributions to helping to do that. And the point I'm going to make is that there are 2 different types of research that we do. There's something called observational research, where we observe what's happening. We don't change anything. And the researchers look at the effect of something that people have in common, such as taking vitamin E to see if there's an effect on heart disease. And there's a reason that I'm bringing up vitamin E because I'm going to explain to you what the pitfalls are of some of this research. So one can do an observational study where you say, let me look at all the people who take vitamin E, and let me look at all the people who don't take vitamin E, and let me see if there are more heart attacks in the people who take vitamin E than all the people who don't take vitamin E. And you say to yourself, oh, that's a great way to do the research. Nothing, you don't have to do anything to anybody that's different. You have to get their information. Obviously, you have to get permission to get their information. But if you get that permission, you could do that research. Then there's something called experimental research or randomized controlled trials, where we actually take people and we randomly, which means by chance, we assign them to one or more groups by chance, kind of by the roll of dice. And one group gets the intervention or gets the treatment. In this case, let's think about vitamin E. And the other gets a placebo, which is something that looks like the vitamin E, but it really is not. It doesn't contain any vitamin E. And the big advantage of that is that when we do this, we don't have a problem with saying, so it might be that the people who take vitamin E are into vitamins. And those people maybe do more exercise because they're more conscious about their health. And so when I looked at the people who had vitamin E and take vitamin E, I might have said, oh, there are less heart attacks in the people who have vitamin E, but it might not be because of the vitamin E. It might be because of the fact that people who take vitamin E happen to be people who are more active and more conscious about their health. So when we do experimental randomized control trials, we eliminate that problem by actually rolling the dice and saying, you take vitamin E, you don't take vitamin E. It doesn't matter to me what you do or what you exercise. And if we do that in a big enough population, all the differences should even out. And how does that make a difference? Well, let's look at the next slide. So which research type is better? Observational studies, as I think I've implicated to you, have biases that may give you the wrong answers. Next. But people who take vitamin E might be different than those who don't, as I mentioned to you. And next. So maybe they watch their diet more. Maybe they exercise more. Maybe they're more conscious about their health. Maybe there are other differences that we don't understand as to why somebody might be a taker of vitamin E. Next slide. So in observational trials, people saw a much decreased rate of heart attacks in patients who took vitamin E. But then they did a randomized trial, and the patients were assigned to vitamin E or a fake pill by the flip of a coin. And what they found when they did the randomized trial is there was no benefit on heart disease. So even though they'd shown this big difference when they did the observational trial, everybody said, oh, I got to go run out and get vitamin E. And all the doctors started giving people vitamin E. When they did this randomized trial, there was no benefit. Matter of fact, it looked like maybe they did a little bit worse. Next slide, please, or next. So that's why it's important to be willing to be in research because you need to actually do randomized controlled trials in order to really get the real answers for a lot of this. And without volunteers for that type of research, we really can't get the real answers. The observational studies can't correct for all the unconscious biases that might occur in what we do. They try to correct, but they just frequently can't. So since it's important to try to do research, and as I mentioned to you, we'd like to try to figure out what things work for African Americans. So there are different ways to help asthma research. You can be a research subject enrolling into a study, or I think as Mary's going to talk about, you can become a patient partner if you have asthma or care for someone with asthma, and you can help advise the researchers and become part of the patient team. As I've seen the comments come across, I've seen people say, the researchers aren't asking the right questions. They're not talking to the right people. And by participating in research, either as a partner or as a participant, that you can help correct that. Because as Mary's going to talk about, she's helped us ask what we think are the right questions. She's helped us kind of think about what are the important answers that people want for the type of research we're doing. So let me ask you this. Would you be willing to be a research subject in an asthma study? And yes, no, not sure. Depends on whether my doctor thought it was a good idea or not, or depends on whether my family thought it was a good idea or not.
So we're seeing great response rates. Just keep on logging in your reply, and we'll share those in just another few seconds. Remember, you can always ask questions if you have questions in the Q&A panel of your control panel, and we'll get to as many of those as possible at the conclusion this evening. All right, looks like we've got about 2/3, 3/4, so I'll go ahead and conclude this poll and share the results.
So 40% of you said yes. About 1 out of 7 you said no. A third of you said you weren't sure. So that we have a large group that either know or not sure. And then 12% said they would talk to their doctor, and 3% said they would talk to their family. Okay. Next slide, please. So I think, as I alluded to, one of the things that are important from our point of view is diversity in research, including different types of people into research. Many different types of people in different ages, different racial and ethnic groups, and different genders to participate in research studies. And so I think I alluded to the fact that Blacks and Latinos make up 30% of the United States population, but they're only 6% of all the participants in clinical trials. And why is diversity in research so important? So as we saw, some groups of people suffer more from certain diseases than other groups. We saw that with African Americans and asthma, right? The cause of disease may not be the same for all groups, right? It may be that, for instance, in certain populations, asthma may be more genetic, and in certain other populations, maybe it's more environmental. Medical treatments may not be as effective for all groups. I think I illustrated this for you or showed you this in relationship to the high blood pressure medications. And individuals within the same racial or ethnic group can respond differently to the same treatments. And diversity or spread in genetic samples and databases is needed in order for us to personalize treatment. We're understanding now that it used to be 30 years ago, oh, I have this medication to treat asthma, I give everybody this medication. And what we understand now is that you're not an everybody, you're you. And you may not be the everybody in terms of responding to that medication. Some medications, some persons may have a bad reaction to that medication, right? Doesn't happen to everybody, but if it happens to you, that's the important piece. And we're understanding that that it's important to do what we call precision medicine, to try to tailor the treatments to you. But without you being in the studies, we can't really figure out what we should do that would be better. Next slide, please. So I want to talk about, Tanya had asked me about our interest in asthma in African Americans and Blacks. So I want to talk about 2 studies that, one which we completed and one was ongoing. I'm going to briefly touch on the first one. Next slide, please. We did a study where we looked at asthma attacks using 2 different types of medications. Again, we had some evidence based on some other studies that we've done that maybe the long-acting beta agonists, which are part of the medications that are used for asthma, maybe Blacks might not have responded to them as well. And so we did a study where we said, okay, let's look at LABAs with long-acting beta agonists versus tiotropium, which is a different type of medication. Because in our study, it looked like maybe patients who were African American might respond a little better to tiotropium. So we did a large study. And next slide, please. Where we randomly assigned 1,000 African American Blacks from across the U.S. to compare the efficacy and safety between 2 different medications that help the lungs open: the LABA, long-acting beta agonist, and tiotropium. And our study was looking at asthma attacks and the time to an asthma attack. And what we concluded, and this was a study now, this was one of the largest studies that had ever been done just in African Americans and Blacks, in the 1,000 patients. So we had a large number of patients, 500 patients who were randomized to get the long-acting beta agonist, 500 patients who were randomized to get the tiotropium. And what we found was, so we'd done observational studies which suggested that maybe tiotropium was better, but we found that actually it didn't make a difference. That it didn't make a difference whether you added long-acting beta agonist or the tiotropium. So here's an example of where we had an observational study that suggested there might be a difference, but when we actually did the the randomized controlled trial, we didn't see a difference. And so the recommendation now is actually not to make a distinction for that. And now I'd like to talk about the study that Mary's been an advisor to us for, which is the Person-Empowered Asthma Relief Prepare Study. Next slide, please. So, so the background here is currently, or any of you have asthma, almost all of you have asthma, probably are familiar with inhaled corticosteroids. They're medications that are used to help prevent asthma attacks, to help decrease the severity of your asthma. And the current ones, almost all of them, are prescribed to be taken twice a day. But it turns out that taking a medication twice a day, especially in a disease like asthma, where sometimes you feel good, sometimes you feel bad, but a lot of times when you're feeling good, you don't really kind of think that you want to take the medication, especially when you hear the word steroid. A lot of patients say, I'm scared of steroids, even though these steroids are actually safe, they're being inhaled. And it turns out that when you look at prescription refills, only about a quarter of patients are really taking their inhaled corticosteroid the way they were studied, which was twice a day. So in studies where medication use is monitored and enforced, having patients take their inhaled corticosteroid, the controller, when they take their reliever, turns out to decrease exacerbations by almost 50% as compared to daily use. So what we said is, hey, you know, patients aren't really using their inhaled corticosteroids. Can we give them a different way to use it? And in a controlled study where we had patients take their inhaled corticosteroid with the short-acting beta agonist each time they did that, when they took their reliever, it looked like you could actually decrease the rates of exacerbations compared to daily use of inhaled corticosteroids. We call the strategy of using the inhaled corticosteroid when you need your short-acting beta agonist reliever medication, we call it PARTIX, for patient-activated reliever-triggered inhaled corticosteroid, taking your controller every time you take your albuterol. So we have shown in the study that I have to lead that you could actually reduce exacerbations if you did PARTIX in a controlled study. But the question was, what happens in a real life study? And what happens actually, that study again included about 15% African American Blacks, but didn't really address the issue for African Americans. And so what we asked was, and we know that the rates of asthma attacks in the African American population continues to be so high, despite all the different interventions that people have tried. And when we spoke to African American patients and to Hispanic Latino patients, what they told us was that they didn't like using their controller medication, that they really would want to use their medication when they needed it rather than every day. And we said, aha, we think we have a method that might work for you. If you can actually take your inhaled corticosteroid every time you feel you need to take your albuterol. So what we asked is, in a real life study, where we're not enforcing people to do things, in the patient populations that bear increased problems with asthma, African American Blacks and Hispanic Latinx populations, can telling patients to use their daily controller each time they use their rescue, the PARTIX that I talked about, can that improve outcomes of importance to patients, providers, and the healthcare system? So we're aiming at having an impact here that's broad. Next slide, please. So we went to our patient advisors and we said, okay, we want to study that. And remember, I told you that when we do research, we have to ask the question and we have to figure out what information we need to collect and what information is going to be important. And so we went to our patient advisors and said, what's important to you in terms of asthma control? You know, a lot of studies do things where they do spirometry and you breathe into a test and they report out, the lung function is improved. Is that important to patients? Yes, we know it might be important in terms of their lung function and how we advise patients, but what's really important to patients? And what patients told us is it's those attacks, it's those asthma attacks, that we call exacerbations that keep me out of school, that keep me out of my job, that keep me from being able to take care of my kids. It's that send me to the emergency room all night, that send me to the hospital for days, and I don't have anybody to take care of my kids. Those are what really you need to help me reduce. That's what you need to show is better. And so we said, okay, we're going to look at exacerbations. and defined as an asthma event with increased symptoms when you have to take steroids. And the question we asked is, can a patient-empowered strategy, PARTIX, where patients are controlling their asthma medications, decrease the number of exacerbations or asthma attacks that occur each year? Next slide.
So Dr. Israel, before we advance, two quick things. Number one, we do have a few comments that people are finding it a bit hard to hear you at times. So if you could just stay close to your mic and speak up.
Absolutely.
And then secondly, just a clarification. So what you're saying is that patients were instructed to take 2 meds when their symptoms were increasing. That is a question that's coming directly in the chat.
Yes, yes. So each time you use your reliever, you take your controller as well.
Yep. Okay, thank you.
Does that sound better?
Yes, much better.
Okay.
Thanks.
So you're going to see a big head here because I'm coming close to the microphone. So I apologize. And to just tell you a little bit about the study that is still ongoing, we have recruited from 20 United States sites across the United States, primary care and asthma specialty clinics. This is a large study of 1,200 patients, 600 African-American Blacks and 600 Hispanic Latinos. It was in adults, not in children, 18 to 75. Uncontrolled asthma. 300 of them in each group are assigned to the to PARTIX, and 300 are assigned to usual care. Next slide. Patients are seen once, and then they're followed for 15 months, and the last patient is going to complete in April 2021. So the PREPARE study research team, I want to talk about that, and hopefully we'll have Mary talk about this. So usually research is conducted by trained researchers. PREPARE was different. We decided we would include, and this is under the encouragement of PCORI, we would include patient partners who work with the team. Next slide. So why involve patient caregivers as advisors in research? We felt it brings important views from people who will be impacted by the study results. We feel that patient caregivers help develop the right questions to be answered by telling us what's important to them. They connect with the lived experience together with the research question. They keep us grounded, and they also can serve as ambassadors to distribute the relevant information if the study results seem to be important. Next slide. So we have a patient advisor population. It includes 7 African-American Blacks and 9 Hispanic Latinos. 3 of these Hispanic Latinos are Spanish-speaking only. We had conference calls weekly at the beginning of the study, and then at least once a month, which are continuing now 5 years into the study, 1 in English and 1 in Spanish. And the patient partners, I think, as Mary will tell you, have been involved in every aspect of our work. They helped us develop the study question. They helped us develop the outcome. They helped us develop the wording and the education tool for the patients. Next slide. And there are a bunch of changes that we made as a result of our patient partner input. We changed the wording of our instructions. We have a survey that we do monthly. The patient partners said it's way too long, got to cut it back, cut it back, cut it back. Every time we met, they said, cut it back, cut it back. And we cut it back and we cut it back. Well, they told us we need to give patients a choice of how to answer the monthly survey, whether they wanted to be online, by phone interview, by mail. But they said that we needed to give instructional videos, and those videos needed to show people like them. They said we needed to pay patients each time they completed a survey, and they helped us figure out how much we should pay patients each time we completed a survey. They also said that, I didn't finish that slide yet, Tanya. If we go back, they also said that patients who fill that, we should give people incentives for filling out the surveys quickly. And so people should be entered into a lottery. And they also said that we needed to make it really easy to get into the survey. And so we had to work very hard with our computer people. So it would be 1 click after you got the notification about the survey. Next slide, please. So the impact, we were able to enroll 1,200 people. There has been a 90% plus survey return rate, even at 15 months. 90% for a 15-month study is just unusual. It's really high. And I think this is directly the result of our patient partners' input. We have an extremely low dropout rate for a 15-month study. Only 17 patients out of 1,200 have dropped out. And 84% of the patients who are assigned to PARTIX say that they're doing the inhaled corticosteroid reliever almost all the time over the 15 months. Next slide, please. And now I'm going to introduce Mary White, who's just been a wonderful patient partner, who's just so giving to her community and has been so giving to us.
So, Mary, we're going to ask you to unmute. We can see you and hear you now. Great to see you. Thank you for being here.
Okay. Okay. Good afternoon, everyone.
Afternoon. And we also have Dr. Graham who's joined us. And Dr. Graham is also, we're going to ask him to unmute his line. He's got the open line. And we are going to have kind of a Q&A between Dr. Graham and Mary as we proceed.
Mary, this is Dr. Graham, and I want to thank you so very much for participating. This whole effort is to be patient-focused, and we as doctors have to hear from patients. So let me ask you just a question to get it started. I want this to be kind of free and open, and let's see where it leads us. So Mary, why did you become a patient partner for the PREPARE study?
Well, I became very excited when I heard about the opportunity to be a voice. I come from a family of asthmatics, and my children suffered from asthma. And it got to the point that every individual I met had someone in their family with asthma. So I wanted to learn more and be a voice of the people who have asthma and what the challenges were that they went through.
That's excellent. Were you or have you been involved in any other research projects, either as a subject or an advisor, or maybe even known people that can relate experiences being in those studies?
Well, it's funny because of doing community work in my neighborhood, a lot of the families suffer from asthma, and we had a lot of housing situations where the housing wasn't up to par. So I actually was involved with a study where I went through the community and asked individuals where they lived and how many times a year were they going to the emergency room with their children. And did they feel that there was assistance to help them with the problems that they were challenging them, like healthy homes, getting their prescriptions. So I have been involved in numerous studies, but nothing like PREPARE.
I hear you.
Mary,
you
I'm sorry to interrupt. Sorry, Dr. Graham, to interrupt, but Mary, we are getting like an echo or a feedback. So if you have a phone nearby, you may need to mute that phone so that for some reason we're getting a weird echo back on your line specifically.
Let's see what we could do. I'm actually,
That was actually better there.
wait a minute, I'm having tech problems. So I actually, let's see. Is that better?
Yes, that's much
Yes.
better. Thank you.
Okay.
Okay, we'll turn it back over to Dr. Graham. Thanks, Mary.
Go ahead and continue. You were kind of in mid-thought, though. Go ahead and continue where you were going.
I was actually going because you asked were I involved with other studies. Am I right?
Right?
And you have to understand, saying involved with studies, it goes far because where I live, people have to have trust because even though we had to study and we had to understand how to read the data, how to reach out to individuals, basically learning to develop a trust with the people in my community. So it was very important for me to talk to people, get to know them, and I had something in common with them. So they wanted to actually be part of the study that we were doing, Strengthening Voices. They wanted to be part of it. I would see people in the emergency room with their children, and they got to trust us, got to trust me.
That's excellent. And that trust is so very critical. And it leads us naturally to our next question in terms of what were your concerns about becoming a patient partner? We know that there have been studies, most notably the Tuskegee study and other things, where Blacks have been actually exploited in the name of research. So how did you address these and how did you factor that into your decision about becoming involved?
When you listen to Dr. Israel, you have to understand that getting individuals who look like you, who live how you live, I wanted to be a voice. I did have doubts. I'm not going to lie. I'm going to be honest. And everybody knows, I'm
Please
just
do.
straight up.
Please do.
And when I sat the first time, I was skeptical a bit. But then when we were asked for our participation, and the individuals, we live in the community, we look alike, we have some same concerns. I don't own a beautiful home. I may have rodents. I mean, I know how it feels. I may not have transportation. So we were all similar. We had similarities. So being part of Prepare showed that even though we were from low income, some of us had different challenges, things going on, a lot of violence in our community, they understood that and they listened to what we said. Like if they needed to know a question or how would you feel about this, how would you feel about that, they weren't looking at us as though, oh, they're just people, we need their input, we don't care about them. We were respected at the table. And that's what gave me the opportunity to tailor my message. And my message was, I don't just want you to hear what's going on with me and mine. I want to make sure if I'm part of this study that you're going to make a difference. You're going to address individuals. And everybody talks about that, those past studies. It's not the same. This is to make a difference. Really to have a team of individuals who, whatever steps that we went through in the beginning, they brought it back to the table to us. It wasn't like, oh, I'm going to get your input. We're going to go here. We're going to work with it. And they wouldn't come back to us. We meet regularly and we discuss what our issues were and we know what steps are going on with the Prepare study.
That's awesome. Hey, I'm going to go a little bit off script, and my colleagues know this, but what advice would you give to patients, other patients, looking, based on your experience that you so eloquently provided, what advice would you give them to do their due diligence to decide whether a study was appropriate for their participation? What kind of tools or questions would you have them ask?
I would say to don't assume anything. I think that you need to ask questions. I think you need to feel comfortable about what you're doing. And if you ask a question and you're not answered, then the realistic fact is that may not be what you want to be involved in. But I think it's so important that we can't, wherever people come from, I think that you can't allow someone to tell you what's needed in your community. I think you need to say, I'm going to take that initiative. I want to be the voice. And it's not always so simple, because if people who take care of individuals with asthma, you may want to make the best for who you're caring for, whether it be a child, a parent, or any loved one. You may not be able to make those changes right away in order to make a better quality of life. So if being in that study or participating will allow you to be a voice to make those changes happen, then you need to go with it. You need to go with it and pick it up and take it and go with it.
That's strong. That's strong. One thing that you said again, and I apologize for going off script, but you're such a rich resource in this regard. You talked about the environmental factors, the violence, the housing, and so forth. And we kind of package that in something called the social determinants of health. Do you feel that researchers appreciate that environment and those factors that have bearing on patients like you with asthma? And should there be more focus on that?
I think that Prepare does, and I think that researchers should actually focus on that, because the realistic fact, if you're a mom or dad and you have 3 children in your home who have asthma, now insurance factors, you may only be able to afford one of those medications, but you have 3 children. Now, the realistic fact, those children, and I believe in this, the asthma, the plans of wherever your children, whether one may be in middle school, one may be in daycare, one may be in elementary, you're going to need medications for all 3 of those locations. So I think it's very, very crucial that you understand what people are going through. You have another family who doesn't want to be homeless, but they live in a place where their house or their apartment is infected with pests, cockroaches, or maybe mice. Now, those are triggers to your child's asthma. You're talking to your owner, but you don't want to be evicted. So you're going to be humble. You understand? So people are up against a lot, or you lose a loved one. And to be realistic, we know that studies have showed that stress and uh, triggers and things like trauma also contributes to asthma. So people are going up with a lot. It's a lot going on. And if you want to do a study about the people in the community that have asthma, and you want to know, you have to touch all ends of what an individual is going through, where they're coming from, and where they live, where they go to school, and other where they work. We can't forget about that, because some of the places you work, you may have an asthma attack because they have incense or other things, that the cleaning devices, you know, a lot of things contribute. So you have to actually touch ends on all of those items, all of those things you have to understand.
That's just awesome. As you become very knowledgeable about research, have you ever felt that a research project was presented to you that you should not have agreed to be a patient or partner? Have you ever found situation? I'm not trying to have you throw somebody up under the bus, but have you found those situations where just the way it was brought to you or the way it was discussed with you kind of alienated you?
Of course. You know what I find quite disrespectful? When there is some type of, you want my input, but I won't give names, but you don't want to compensate me for my time. You you're not listening to what I'm saying to you. And that alone, and I don't trust you, because this is something else with numerous studies in my community at once upon a time. When you get input from people who live in a particular community, you need to report back your findings. I find that quite disrespectful, to get data and not report back to individuals, or you're going to pay them with a gift card and they go to use the card and the card malfunctions. I mean, I've seen it all, and I'm quite sure there's going to be others coming, but those are things that really turn me off, and they turn off individuals in my community. And that's why a lot of people say, I don't want any part of research studies, because of things that people have done to them in the past.
I hear you. And again, going off script, do you still feel, though, that it is so important for us to be involved in a respectful fashion so that that research does tell people about us?
Yes, I think it's very important. And I will always feel that way. You need to know where people come from. You need to know, listen to their voice. Realistic, the crucial, you have to listen to what people are saying. Your participants, you have to listen, not just, write down, oh, this sounds good, let me write this down. No, you need to listen to the voices of the people that you're trying to learn information from.
That's so true. And I got to tell you, even being an African-American provider, when we got into electronic medical records, I had some of my Black and white patients said, Dr. Graham, I need you to stop typing and listen to me, and that's just something that technology has thrown upon us, but that is so important. And we're taught to be active listeners, but sometimes we fall short.
Yes.
Well, Mary, the next question, I've got the answer, but I want you to share it. You feel you're making an impact?
Yes, I do. Yes, I do. I go back to my mom, though. Look, I might be making an impact, but there's always more work to be done. If I can help someone feel confident about taking part in a study, or taking part in their community, or being a voice, or asking questions, just to say, what can I do? Not just give your child or your loved one's medication. Communicate. Make it that you are in a relationship with your individual, your primary care person, your kid. You're never going to be doing enough. So I hope and I pray that hope no one gets offended. I hope and pray that I keep making an impact, because there's always work to be done. Never know it all. I'm still here learning. And unfortunately, people in my community and my family have still been diagnosed with asthma, but at least now I know I can help them, because I can ask what one person said to me. It was a simple question. No one never said it after 10 times being in the emergency room with my children. Where do you live? So now I take the knowledge that I receive from different organizations I'm part of and make that voice be heard and help others. We always have to help others.
Well, I'm going to turn it back over to Tanya, but Mary, I think you have been such an incredible part of this. And I can't thank you enough individually or collectively for the program, for being honest and being an advocate. And I think you've made an impression that we as the faculty on this could never make. And I just want to thank you from the bottom of my heart.
Thank you for having me.
Absolutely. Thank you so much, Dr. Graham, and thank you, Mary. So incredibly powerful. We do have about 5 minutes left, and I know that Dr. Israel is going to have to leave right at the top of the hour. So I want to just take a moment and thank him for his time, for his expertise, and for his connection to Mary. What an amazing patient advocate and champion for research. I love being a part with her. So at this point, let's go to some of the Q&A that we've got that's come through. Yeah, go ahead, Dr. Israel.
I would be interested in seeing if there's been a change. If we could ask that question again.
Sure.
After Mary spoke.
Yes.
So, would you be willing to be a patient advisor for an asthma study?
Absolutely. Let's go ahead and see if we can get that poll launched. Let's see. Sorry that I have to move a couple of things around in order to see it. All right. So I'll go ahead and launch that poll for everyone. So would you be willing to be a patient partner or advisor for an asthma study after hearing what you've heard this evening from Mary and Dr. Israel and Dr. Graham? Yes, no, not sure. Depends on whether my doctor thinks it's a good idea, or depends on what my family thought. We'll give it just another moment. We've got well over 400 people that have joined this evening and are actively engaged in the polling and dialogue. So want to make sure we get a good response, and looks like we're just at about 60%. So give it just another couple of seconds. All right, I'm going to end the poll and share the results.
Okay, that's great. Mary, you do wonders.
Yes. Don't you wish we had a Mary in every single interaction when we're talking about?
Absolutely.
Yeah, it's great. Fantastic. Well, again, I want to thank you, Dr. Israel, because I know that you have another commitment and are going to have to step away. We don't want to keep you, but we do appreciate your expertise. It's been invaluable during this time this evening. I'll go
It's
as
a pleasure. It's been an honor. Thank you so much.
Thank you. As I said, I'll go to some of the key questions here for just a moment, because we want to hear from you, those that are on the line that have been asking questions. And I'll field this first question. Dr. Graham, if you could turn on your camera, I think that many of these will go to you, as well as Dr. Israel may have to step aside. But the first one is, what role do you feel that environmental racism plays in the disproportionate numbers of African Americans with asthma?
I think that's very real. I think that environment plays a very significant role. There are studies that show that people who live near highways where there's more pollution, more exposure to auto and truck exhaust, have increased rates of asthma. Their children have more asthma attacks, and they visit the emergency room more often. And we know, when you look at the distribution of where African Americans live, that they disproportionately live near highways, near these areas with high traffic. So that is definitely an issue that relates to the effects of asthma.
I'd like to add to that, if I may. I grew up in Chicago and had asthma as a child. And I was very near the Inglewood neighborhood that everybody's heard of. And there's been studies that I've read, and Elliot, I'd appreciate your comment. We're living in an environment of violence and crime and threat that is an impulse that stimulates an inflammatory response of, what we call the fight or flight. Maybe you could comment on that, because that's an environmental factor that I don't think too many people think of.
Yeah, so that actually has been studied as well, Leroy, and there's clear associations between social stress, which is, I think a big factor. It's violence, it's economic dislocation, it's economic insecurity, it's food insecurity. All those things feed into, asthma is not in people's heads, but that doesn't mean that your body's stress response can't make an asthma attack worse.
Absolutely.
So our next question is, how can someone actually get involved in research? How can they begin to partner, like we heard from Mary?
I think, it's a matter of looking for studies. You can go on, if you have access to the internet, there's something called clinicaltrials.gov, which is a repository of all clinical trials that are going on. You can type in asthma, and then you can look at the different asthma studies that are going on. You can look to see, you can type in your location, I believe, and look to see which studies. So you can put in asthma and then put in, Chicago or Dallas or whatever, and see which studies that are doing asthma studies are recruiting in your area. And it tells you where to contact people. So I think that's a great way, and that's the most comprehensive way to do that if you want to do it actively.
Yes. And I'll just reinforce that on the allergyandasthmanetwork.org website, we have a wonderful tool that's very user-friendly, that is comprehensive of all of the trials that are available on clinicaltrials.gov, even beyond asthma. And so if you have any type of condition, want to get involved in asthma studies or other studies, certainly go to our website at allergyasthmanetwork.org, our research section, and we can help support you through that antidote tool to find the clinical trials near you. So our next question comes that says, in the study with African Americans and Latinos with asthma, were comorbidities a factor in the ER visit and asthma-related deaths? Did they actually look at comorbidities in addition to just asthma?
So that study's still ongoing. So the PREPARE study, the last patient is going to complete in April. And we are collecting information on comorbidities to see whether that affects the outcomes.
Yes. And then, of course, we have to have a COVID question. It wouldn't be a webinar in this pandemic time without this. And so, Dr. Graham, because COVID certainly adversely impacts the lungs and the respiratory system, how do asthma disparities impact the higher mortality rates in African Americans and COVID?
That's a superb question. Asthma, poorly controlled asthma, is like a lot of other conditions that the intensive care doctors have reported, that people came in already unregulated. And COVID, I've heard people say it's a great disruptor. So those kind of things in our body that control and contain, if they're already out of whack, so to speak, what this virus seems to do is exploits that. And I wrote an editorial early in this after kind of interviewing a number of my critical care fellows, and they said, this person came in with a high blood pressure, this person came in tight, not moving air, history of COPD or asthma. So I think it's been a big factor, and again leads back to a lot of these social determinants of health, because a disproportionate number of these patients came in without a medical home. They did not have a place where they got usual care for their chronic conditions. And I think the story is still being written, and there will be even more to come. But I think that this country and we providers have a lot to learn in what's happened in COVID and the disproportionate morbidity and mortality of African Americans who have been devastated by the COVID pandemic.
Thank you. So one final question for you, Dr. Israel, and then we're going to do our conclusion and wrap up. Have you seen any data that actually demonstrates the lifespan of people living on asthma medication versus those not taking their controller medication? And how long do they live? Do their lungs and lung function worsen over time?
So we know that uncontrolled asthma is associated with a shorter lifespan. It's And so that's one piece. Clearly, there are asthma deaths. There are still about 4,500 to 5,000 asthma deaths a year in the United States, and those are again disproportionately in Black and Hispanic Latinx populations. We also know that in pregnancy, I think this is just an very important piece, that uncontrolled asthma in pregnancy, it's not only the effect on the woman. We know that the children of pregnancies where the asthma has not been well controlled are smaller. They're more likely to be premature, and they themselves actually can have worse lung function. So there are many reasons to really work at getting your asthma under control.
Well, again, thank you to Dr. Graham, to Dr. Israel for being here this evening, and thank you to the hundreds and hundreds of people that are on the line. This effort, as we said, is ongoing. So tonight just starts the conversation. We want to keep the conversation alive. And now we have an online place that's just for you. It's called Black People Like Me. It's a closed Facebook page, and our success will come from engaging with you over the next 6 months. So we'll continue to host these types of webinars, but this private Facebook group is an area that you can go on to explore thoughts and feelings and how we can work together to truly make an impact and a difference in the community. It also, we're hoping, will become a trusted resource where you can ask questions of experts like Dr. Israel and Dr. Graham and take part in those conversations directly with the experts in the field. So our request of you is to be creative, be social, and stay engaged throughout this 6-month period. Post a drawing, a photo, share the success of your own asthma story or the challenges of your own asthma story. And just continue to stay engaged in the months that are forthcoming. We'll use these creative posts and actually develop artwork and celebrate our progress month to month. We do have a hashtag BPLM art to tag your creative post so we can find them more easily. Also, on your Facebook page, you can always tag hashtag BPLM or Black People Like Me, and we'll be able to follow the conversations online through Facebook and Twitter as well. I want to thank our patient advisors that have continued to help us develop these series, as well as this very first piece of art. And here you can see Charmaine and Charnette, and again, Mr. Edwin Bolden, who shared last time. Here's the very first piece of art, and it is with an inspirational quote from Maya Angelou, and definitely a piece that I keep before me as I'm doing my daily work at Allergy and Asthma Network. Again, we want to thank each of you for being here today. We are going to ask you to complete a short program evaluation survey and post-test, and save the date for our next upcoming conference. That will be on February 11th. And we will send out a registration link forthcoming. We have our Asthma 360 registry, which again, there are incentives to join and participate. And you can also learn more about our community outreach programs like Not One More Life Trusted Messengers. If you're living with asthma, you want to get plugged into an asthma coach through telehealth visits or remote monitoring through remote monitoring tools, we have all of those free of charge for you and at your disposal. Please log on to our Facebook page, stay engaged there. And again, the Q&A as well as the PowerPoint will be posted on our website shortly after this evening's webinar. Again, I want to say thank you to the panel, thank you to the organizers, and thank you to PCORI. But most of all, thank you to you for staying engaged and continuing the conversation of Black people like me. On behalf of Allergy and Asthma Network and the staff, thank you and have a great evening.